grace period for everyone to join. But with that being said, it's a few minutes past 1 and we'll go ahead and get started. So thank you for joining me today. My name is Mike Jersey. I'm Clinical Director for the Support Services Team, or SST. And for those of you who may not be familiar with us, I'll give a little bit of an overview about what it is that the SST does. But we basically receive referrals from the Division of Developmental Disabilities so that we can provide additional resources, consultation, behavioral supports to people who have been identified as experiencing behavioral challenges and or medical challenges. And we're really just an extra set of eyes and ears to whatever those challenges may be so that we can support everyone in working towards a decrease in the frequency and severity of those challenges. A major component of the services that we provide is training or learning opportunities, as we've coined them at times. And a few years ago, we were asked to expand our scope of trainings, and we began to offer some community trainings that we did in person across the state regarding various topics. And sorry, I'm getting some messages at the same time, some various topics. And we then, when the pandemic started, we moved to online so that we could continue to provide these trainings, even though that we couldn't be in person. And since that time, we've actually been able to reach many people across the state and have much larger learning opportunities and training experiences for the people that are within our field. So this is one of our learning opportunities that we're offering this month. And specifically today, we're going to be speaking about Prader Willi Syndrome. Just before we get into everything, just a couple of housekeeping details. We will have some opportunity for questions. So there'll be a break in the slides where we can stop and I can ask if there's any questions out there. Again, your microphones and your cameras are muted, so I can't hear you, but we'll monitor the chat. And at those natural breaking points, we'll ask if there's any questions. And then by all means, I'll try to do my best in being able to answer your questions and respond appropriately to any questions that are asked. Also, we are offering free CEUs for this presentation today, but we ask that you please allow 14 business days for us to be able to send those CEUs out to you. There are many people that are signed up for the training today, close to 300 participants. So after we go back and we are able to print all those certificates, it just takes a little bit for everybody to get those certificates sent out. If you do not receive a certificate within those 14 business days, then we'll put up some contact information of who you can contact so that you can get that certificate and that acknowledgement of that CEU. We also have, just because I gave a little bit of an explanation over our training program or our learning opportunities, we have a website, which is icpn.org, I believe. But I think we'll double check that. I always forget our website, so I apologize. But on there, there's a professional development link, and you can go and access that website and be able to see all of our upcoming learning opportunities that we will be offering with CEUs available as well. And then there'll be links to be able to register for those. So with that being said, I think that covers all of our housekeeping details, and maybe we can go ahead and jump in and get started for today. So what are we going to talk about today? Obviously, Prader Willi Syndrome. But we're going to give a little bit of an introduction of what Prader Willi is, talk about the developmental stages of Prader Willi syndrome. And, you know, Prader Willi is a very complex diagnosis that affects so many areas of a person's functioning, whether we're talking about physical functioning or we're even referring to cognitive, psychiatric, things of that nature. And so what the purpose of this training is today is a very basic training to bring some of those complexities and really break them down into small, really understandable components so that you'd be able to walk away with understanding the crux of what PWS or Prader Willi syndrome is, and then maybe have some treatment considerations or just some ideas of how you can support somebody with Prader Willi syndrome going forward. Okay, so like I said, we'll talk about some features, we'll talk about treatment considerations, and of course, we'll stop for questions. Okay, so just before we get started, this training really came about. It's funny how in life you can sometimes just back into things. And when I joined the SST at the beginning of our development, it was back over 10 years ago now. I never thought that I would have worked with so many people that had Prader Willi syndrome. In fact, I did not even know what that was when I first started on the team. I was still technically completing grad school, and I would hear some of the other team members that had been in the field for much longer than I have. They would refer to Prader Willi syndrome, and I thought, wow, what a strange sounding diagnosis. And I would think, like, that's really odd. And then I'd like to know more about it. But then, of course, as we all probably can relate, life goes on and we're busy and we're constantly putting out fires in our field, trying to be on top of everything. And it doesn't always leave a lot of time for us to really dive in and do the research that I think that we would be able to do if we felt we had more time. So just by happenstance, I started to begin to receive some referrals for people who were diagnosed with Prader Willi, which then presented the opportunity to learn more about who I was supporting. And from there, I just found that it's a very fascinating diagnosis, a genetic disorder, actually, that is often involving a failure to express paternally inherited genes. And it is more common than you might think. About 1 in every 12,000 to 15,000 births are diagnosed with Prader Willi syndrome. And as I alluded to before, this syndrome, this genetic disorder, really impacts the person in every aspect of their being. We're talking about their physical functioning, their cognitive functioning, psychiatric stability and functioning, as well as it creates an area where the person develops some really interesting behavioral traits, that learning history. And a lot of their at the basis of those behavioral traits, it really is rooted in some of the inabilities that a person may experience because of the way that those lack of genes have expressed themselves. Pretty much, the Prader Willi syndrome really affects the hypothalamus in the brain. And the hypothalamus really is this small little part of the brain that is responsible for so much. It is basically the command center of our brains. And because of this, there's a lot of different disorders that might be connected to the hypothalamus, but it's very challenging to identify some of these disorders because the hypothalamus is so responsible for so many things. It really is a strong piece of our brain, or rather an important piece of our overall functioning. The purpose of the hypothalamus, not only just being the command center, but the purpose of that is to maintain homeostasis, that all of our functions in our body are in balance and nothing is really out of whack, so to speak. So with that being said, the hypothalamus may be involved in many different areas, such as regulating our body temperatures, controlling our appetite and our thirst, sending those signals when we really need to refuel or rehydrate. It can help and is involved in weight control. Part of the thalamus involves emotional processing, sleep, sex drive, even heart rate, blood pressure, amongst others. Even digestion is related to the hypothalamus. And so if our hypothalamus is out of whack or it's not functioning appropriately, then that can send us out of that homeostasis. And our bodies might either react in a way where we're overproducing certain hormones, or we have overactive bodily functions, or we can go the other way where it's underactive and we're not able to produce certain hormones or things of that nature. And then that really can affect our overall functioning in life. The hypothalamus is also associated with growth hormone. So growing as a child, but then when we are adult, that ability to stop growing and just manage where we're at. Also, the hypothalamus, coincidentally, is associated with stress. As stimuli comes into our system and we're processing this from our five senses, then our hypothalamus takes this information and rates it and then engages the body in appropriate responses. So when you experience stress, then the hypothalamus most likely is going to recognize those different stressors and will then engage our hormones. And this is where we might have some adrenaline or other hormones that get engaged and give us the energy boost that we need to deal with a stressful situation or distressing situation and respond appropriately and ultimately maintain our health and safety. And likewise, when a person has experienced a traumatic experience, that hypothalamus essentially becomes overloaded, and that leads us to those signs and symptoms of PTSD. So this is just to highlight a little bit that the hypothalamus is really our command center. It really is an important structure in our brain. Not that there isn't anything in our brain that isn't important, but when there is dysfunction with the hypothalamus, it's going to affect many different areas of our being. And that is very true with Prader Willi. And we definitely see this in two different stages of development. The first stage of development for Prader Willi is actually that stage between birth to around between 2 or 5 years old. And this is the failure to thrive stage. And this is where we see that, that underproduction of our bodily functions. We see a person who has a very low birth weight. There's decreased activity in the womb, and babies are often arrive past their due date. So we even start to see some of these changes well before the baby has even been born. And obviously, then we see co-occurring developmental delays, where the child is not meeting those developmental milestones. And when they do, it's often very late. When born, babies often experience floppy baby syndrome, and that's a count of poor muscle tone. And so you literally see, it's named appropriately, that the baby is not likely to support their own weight. Obviously, infants struggle with this, but when it is time for that baby to be able to lift their head up, move their head, sit themselves up, oftentimes a baby with PWS or Prader Willi syndrome is not able to do that. Even just grasping, reaching out and grasping, sometimes that even is delayed because of the poor muscle tone. There are feeding difficulties present early on in their infancy because there's a poor sucking reflex. And I'm sure most of you are aware that that's something that's an innate reflex for anyone that's in their infancy. A baby just instinctually will begin to suckle, and that's their main source of nutrition most of the time. But for PWS, we don't usually see this. And because of that, we see very slow growth and it's just very slow to gain weight. Physically, their features, they have very small hands and very small feet, and this tends to persist throughout their development, even into adulthood. Many people with PWS are going to continue to have those petite-sized appendages, such as small hands and feet. During their infancy and early childhood, you'll see excessive sleepiness from babies with PWS. And of course, the delayed milestones. Oftentimes, babies with PWS may not speak their first words or make their really true utterances until at times well into 2 years of age. Same thing with being able to engage in those gross motor skills, such as walking, standing, sitting upright, things of that nature are heavily delayed and might not occur until age 2. And then, like I just said, speech and language processing and development is often delayed at this age as well. So then that's the first stage. We are experiencing somebody that is a failure to thrive. It's the underproduction. But then something happens after that person hits that between the 2 and 5 year mark. It's almost like their body has been trying to start that engine, and they've been trying to lay on the gas and turn that key to get that body started and start to engage in that growth hormone and meet those developmental delays, that eventually that key turns and that engine starts. And then we see that overproduction. And now the body does the complete opposite. The body is revved up, and it goes into really this active mode of overproduction in many different areas. And this is where we see something that I think is really the hallmark of PWS. And it's what we experience oftentimes because we see a lot of behavioral features, psychiatric features related to this, that the person then begins to have an increase in appetite. And not just any old regular increase in appetite, but it is this increase that becomes problematic to the point where the person cannot feel as though that they're satiated. No matter how much they eat, they do not feel satiated. And even if they eat healthy, more times than not, they're going to be really they're going to be very easily prone to gaining weight. And so obesity is very common, not always the case, but 90% of the time, obesity is a common feature for people with PWS. So as that person's system has jumped into overdrive, they're constantly feeling that sensation for hunger, and they're gaining weight. They're seeking out food. And if they are denied food or access to food, then that's where we start to see some of those behavior problems. And this often refers to tantruming-like behavior. We also see several areas of impulsivity, especially in the area of behavior that can be self-damaging. A person with PWS might be impulsive in many ways. First, they might be impulsive with food items, even leading to eating non-edible food items and engaging in pica. This also might lead to a person engaging in self-injury, physical aggression, and other types of behaviors that might be self-harming or harmful to others in response to not being able to get their wants and needs met, or that perception of not getting their wants and needs met. We see that there's an increase in social skills, whereas the person in that first stage of life, where it was failure to thrive, they may not have been able to develop some of those naturally occurring social skills. Suddenly we see a large increase where the person becomes highly talkative. It seems like their vocabulary is ever increasing. They're communicating a lot. But then they're also communicating things that sometimes seem inappropriate, asking questions repeatedly, perseveration, things of that nature, not being able to let things go, not being able to engage in appropriate social interactions, and then being able to cope with different social interactions as much as what we see in this stage of their development. So this is just a little bit of a diagram to kind of highlight how that development might occur for some people with PWS. Like we said, birth to 2 years, but that can really vary, maybe 2 to 5 years, just depending on the person. There's always variability for our people, but we really see in this diagnosis for people with PWS that to receive a diagnosis, we see this timeline where we start to notice hypotonia or that poor suckle reflex. And hypotonia means that there is deficient muscle tone in the body. And you might think that, oh, muscle tone, that doesn't sound so bad, but really muscles throughout our body are responsible for a lot of our biological processes. So that varies from our respiratory functioning and the raising and falling of our chest when we're breathing, being able to inflate our lungs and exhale, things of that nature, to digestion, and then also elimination. Muscles are involved in every aspect of our being, not just whether or not we're able to lift a certain weight or whatever. It also involves many different processes. So if we have low muscle tone or poor muscle tone, then you can see how many different biological functionings could be affected. In fact, many of them are, and we see many complications, medical complications, and many medical concerns arise when we are supporting people with PWS. As that person ages, we start to notice some other milestones for PWS to receive a PWS diagnosis, and we start to see those global developmental delays. Which intellectual disability is very common for people with PWS. And usually a person is diagnosed with a mild intellectual disability. Between 6 years and 12 years, we are also now seeing that excessive eating, which is also known as hyperphagia, and a preoccupation with food. And we're seeing obesity if that is not controlled. And then into the adolescence, we're seeing some cognitive disabilities, mild intellectual disability, like I referred to before, that excessive eating. And then we're also seeing a dysfunction in the development of the sexual organs. As an adult, their puberty might be delayed, or I'm sorry, as an adolescent, puberty might be delayed. And I can't remember the statistic off the top of my head, but a good number, and I want to say up there around 80% of all people with PWS actually are sterile and not able to reproduce. And some of that is because of the underdevelopment of their sex organs. So we see different conditions such as hypogonadism and other things that really impact that sexual functioning as that person goes from adolescence into adulthood. So features of PWS, I've actually been communicating a little bit of that overall, but we see stature, so we have physical features. It is very common for a person with PWS in their development to develop different physical features that might really impact their ability to engage in gross and fine motor skills. First off, many people are prone to osteoporosis. They're also very prone to hip dysplasia, and they're also prone to scoliosis. So as that person is developing, and as their system revs up in that second stage of development, we're starting to see that there's some physical abnormalities to their development that can create further problems. So with stature and hip dysplasia, I mean, that's associated with obesity at times as well, but that can also affect other aspects such as gait and really mobility in general. And oftentimes what we see with people with a PWS is that they are often not very mobile. You might see them engage in more of a waddling gait when they are active. But then a lot of times they will choose activities that they can do that are stationary, which again, everything's interrelated, is not necessarily healthy when we're working with people who suffer from obesity and then the co-occurring medical complications that come along with that. We actually see facial features that are common for people with PWS. I believe I have a few pictures in here in one of the next few slides, but there's a very narrow nasal bridge. With people with PWS, we see almond-shaped eyes, a very thin upper lip. Those are some of those features of facial features. And these are one of the few diagnoses out there that you can actually see some of those physical manifestations in that person's face. Other diagnoses that come to mind would be fetal alcohol spectrum disorder. There are facial signifiers with that diagnosis. And then, of course, the probably most commonly known Down syndrome also has some of those significant facial features or facial features that are very common. As I mentioned before, appendages such as small hands and feet, different aspects of sexual dysfunction, especially in puberty, in both men and women. It's not just relegated to one sex or gender over the other. We also see a lot of visual abnormalities with people with PWS. Many people are diagnosed with myopia or nearsightedness, and we also see a high incidence of astigmatism. Like I said, scoliosis, osteoporosis are very common and can affect that person's mobility. Oftentimes, osteoporosis may lead to fractures in that person, but because of the person and some of the features of PWS, we might not even know that they're having any of these physical complaints. There is a high pain threshold. It's also labeled as pain insensitivity for people with PWS. And then again, that goes back to the brain being able to interpret signals that it's really receiving from the body, or different input rather, and being able to interpret it appropriately and then engage the body in the appropriate coping mechanism, so to speak. And by coping mechanism, meaning the appropriate function and how to deal with that. For example, if we had a broken bone, then there would be a lot of different physiological responses to help mend that broken bone, including swelling and pain to let us know not to move in that direction or not to do that anymore. All of these are signals that we would typically receive. And then that would affect and really impress upon us what our behavior, or dictate our behavior rather. But for people with PWS, they're not receiving those same signals. So oftentimes when we see different signifiers that something is not going well for a person with PWS, that they're not feeling well, that they are experiencing some type of pain. Usually when we become wise to this, it's really where there is a specific situation where this person's health has gone really past the point where it should be for other neurotypical people. So if a person is reporting that they're in pain, that must mean that they're in incredible pain and that there's something really wrong in their system. Likewise, it's not common for a person to vomit when they're diagnosed with PWS. They have a high vomiting threshold. And again, that has to deal with the body being able to interpret different signals appropriately. But then also that takes a lot of muscles working together to get that body to convulse and bring items up from the stomach cavity and out of the body. So if you don't have the tone, the muscle tone to be able to do that, it's unlikely that you would be able to vomit. And vomiting really is the body's way to immediately eject something that shouldn't be there. Likewise, oftentimes if a person is complaining about not being able to go to the bathroom and that they have some discomfort, different digestive issues such as GERD and gastroparesis and necrosis of the bowel and things of that nature are common for a person with PWS. And again, that comes back to that body's ability to effectively eliminate and have those muscles and send the appropriate signals to be able to do all of their bodily functions on time and appropriately and in a healthy manner. So when a person with PWS is really starting to complain about physical sensations, they're sick or things of that nature, it's usually that they're in a bad way at that point because their body doesn't typically recognize these different sensations, which then just really makes things challenging for us. Again, going back to that earlier description of the functions of the hypothalamus, that includes so many different aspects of our physical functioning that it also involves body temperature. So even when the person is sick, we may not see a fever. We may not see that spike. So all of these indicators that we use to interpret whether or not somebody is feeling well or in some type of pain, we often don't see this for a person with PWS, which can make things very challenging in regards to providing a full scope of services and making sure that this person is in optimal health. Oh, and I forgot to mention, seizures are also very common with people with PWS. And it's very common that they will receive treatment for seizures, including medication, and that seizures will be controlled through medication. But medication sometimes has a double-edged sword with people with PWS. Whether we're talking about medication to address psychiatric needs or health needs, a person with PWS, with all of these different medical concerns and different features of the disorder, we also see that that person is not able to metabolize medications in a similar fashion to somebody who is not diagnosed with PWS. So we see a lot of adverse side effects from medication from a person with PWS. And with that being said, even seizures and the treatment of seizures can be complicated at times. And this is why that person may continue to experience seizures from time to time. It is very common in their development, in those developmental stages, for them to have seizures. But you might see them in adulthood too, because medicating a person with PWS can be challenging and tricky because it depends on their body's ability to effectively metabolize the medications. And that can present with so many different challenges as well. Oftentimes, if a person is over-medicated, we will start to see that increase in lethargy. Other side effects could be saliva production. And believe it or not, people with PWS have swallow issues. They also have thicker than normal saliva. So a lot of times, a person with PWS is going to be prone to choking, and there's just a natural choking hazard. So if we are relaxing their body, we're giving them a medication that's going to overproduce the saliva, we might be creating further issues for a person with PWS. So long story short, as I've mentioned many times already, the person with PWS is affected in many different areas of their functioning. And we have to definitely look into every aspect of their lives so that we can make sure that we are trying to provide them with enough treatment to give them as much comfort and avoid a lot of these potential hazards that are very common for people with PWS. This is just a little illustration of some of those physical features that you might see. So this is literally an illustration where you see almond-shaped eyes, a thin nose, thin upper lip. The mouth is often downturned and the person is overweight. These are some photos of how this might manifest for a person in real life. You see definitely on the left-hand side of your screen how the person is very overweight, but yet the limbs and specifically the hands and feet are not proportional to the rest of the person's body. You might even see that there's a difference in that person's stature and the way that they are able to hold themselves up. And it's due to many of the physical traits that many of the people with PWS experience. And then on the right hand of the screen, you can see in those two headshots where you see the shape of the eyes, the thin nasal bridge, as well as the thin upper lip. It's kind of hard to see in these photos that the mouth is downturned, but these are some of the subtle physical features that you might notice in a person with PWS. Cognitive features. So we talked a lot about the physical and the medical, but there's also cognitive features associated with PWS. And we see this most in childhood with the gross motor delays. So not being able to walk when there's typical development. Usually a person will start that process around age 2. Even beyond then, there might be less activity when walking. It's really important for a person with PWS to engage in exercise so that they can begin to familiarize themselves with different physical functions. Because a person with PWS, especially in childhood, is not going to be very active. Even though their hunger and their appetite will increase, that doesn't necessarily mean that the rest of their body will. In terms of that activity. We often see those language delays for the first few years of life, but then it goes on the other side. As that person gets into their older adulthood, their adolescence and into adulthood, you actually see quite the opposite. Many of the people with PWS that I've served and support and had the opportunity to get to know have been incredibly articulate. And it then becomes very challenging because it's really easy to overestimate that person's ability in regards to their cognitive functioning because of how much they're able to express themselves. That expressive communication at times is very skilled. Learning disabilities is very common for people with PWS when they are in their childhood years, in that development. But the interesting part of this is that reading and problem solving really is not necessarily affected by this. And you'll see this as a person develops and as they get into their adulthood. There are different aspects of their behavior where at times the person with PWS can really seem very quite astute. But again, that leads us down this road to overestimate that person's ability in other areas of their functioning. It is true that most people with Prader Willi syndrome are diagnosed with intellectual disabilities. And it is possible for them to have intellectual disability in different ranges. But most people truly are diagnosed with a mild intellectual disability. So this is where that person really is able to do some basic academic skills such as reading, writing. They're able to communicate, expressive communication verbally, and they're typically able to understand some of the concepts that are communicated to them. But that doesn't necessarily mean that they are able to understand and really truly function effectively in other areas of their development. Intellectual disabilities means that there's an impairment in every aspect of functioning. And that goes from something such as self-care, safety, community access, interpersonal effectiveness or relationships, even to being able to identify and appropriately engage in leisure activities. And we definitely see with people with PWS the struggle to be able to engage in some of these different areas of their lives effectively without the support of others. Some behavioral characteristics, temper tantrums. A person with PWS is prone to engaging in tantrum-like behavior. People with PWS have been known to be quite rigid. They like to know what their schedule is. Oftentimes, they become very fixated on that schedule. They like to know what's coming next. And when there's any type of deviation from that schedule, then you start to see where this rigidity comes out, and even some controlling and manipulating like behavior. Predictability really is best for a person with PWS. They struggle to cope in moments of downtime and moments of the unknown. So some of their behavior has been labeled as controlling and manipulative, but it's because they really have an impairment in being able to engage in healthy and appropriate coping skills. In fact, a lot of times when we're supporting people with intellectual disabilities in general, we see impairments in being able to effectively cope with the rhythm of life, so to speak. Different changes that occur in our daily schedules, changes in environments, being able to be flexible in environments with unexpected stimuli, meaning that, maybe somebody isn't there on a given day because they were sick, or environments that are loud and noisy. Oftentimes people with intellectual disabilities struggle to be flexible, and that is very true with people with PWS. That flexibility really isn't there. This is a person that often sees things in black and white thinking and is very rigid. There's also a lot of impulsivity associated with the diagnosis of Prader Willi syndrome, but there's also some overlap here again with people with intellectual disabilities, because impulsivity is inherent in that diagnosis as well. So unfortunately, that also means that there's impulsivity in behavior that might be self-damaging. So when this person experiences changes to their routine, when they're not able to feel as though that they're in control of certain aspects of their routine or their daily life, then you might see some of this tantrum-like behavior. And this could involve self-injury, which is very common for a person with PWS. Again, because of that high pain threshold, they're not necessarily going to experience the same amount of pain that maybe we would if we were harming ourselves in some way. You'll see a lot of non-compliance from a person with PWS, especially when you're asking them to do things that are not already agreed upon as being a part of their daily routine. You see compulsive behavior, and this might be compulsive on the verge of OCD-like behavior in collecting, hoarding, skin picking, repetitively skin picking, things of that nature, but also compulsive if we are even talking about the whole overeating aspect of PWS. And that might lead to pica behavior at times, like we already discussed, because that person is going to compulsively and impulsively ingest items, maybe to try to satiate themselves, or even to engage in self-harm. It does become very challenging though when pica behavior occurs, because we're not necessarily going to see the same type of natural body functions to be able to deal with a foreign substance in that person's system. So that person's not going to be able to vomit that item out, and they might not be able to pass that item through elimination of their bowels. So this can lead to many different disorders or further complications rather, where the person then might need to undergo more medical treatments, even have some surgery if pica behavior is too significant and too serious. Which then also leads to other complications, because there is a narrowing of the trachea that's common. There's this thick saliva issue. There are natural breathing issues that occur. Sleep apnea is very common for people with PWS. So then you can see that anesthesia and going under for any type of surgery could be very, very risky for a person with PWS. We also see talking too much. That has been listed in a lot of research that I did as a behavioral issue. I don't think it's so much a behavioral issue as, again, a person really expressing themselves, but there is a little bit of perseveration that occurs, almost like a reassurance that the person needs certain things to happen. And all of this kind of makes sense if there is a lot of controlling and manipulating behavior. If anybody ever feels as though that they have lost control over certain areas of their lives, then it's very common that that person's response is to try and control what they are able to. And they do it with great vigor and determination. So it's not surprising to me that a person with PWS, when there's so much that's out of control for them, that they would try to control their routine, the activities that they engage in, as well as their conversations, their social interactions, that they would perseverate on certain items to make sure that things are done a certain way and things of that nature, because those aspects of their being are in their control to a certain extent. And because of this, what I was kind of highlighting already in that behavioral piece and that desire for control or that lack of ability to control, that sometimes then leads us down that road of some psychiatric features that might lead to diagnoses of psychiatric disorders. We often see mood lability or mood swings for a person with a PWS. And again, that's probably because impulsivity is really inherent to their cognitive functioning. So we definitely see a person be able to shift very quickly from everything's okay to what do you mean I'm not doing this today? And then quickly go into some difficult behavior such as self-injury and things of that nature. We often see depression. And I think that this makes sense if you really think about it. Again, somebody who's out of control might begin to develop depression. Also, people who are riddled with medical conditions and they're constantly going from one situation to the next where there's another medical complication, they often experience a lot of depressive symptoms. Again, I think that the lack of control and the lack of being able to feel well really adds to this. And like with depression, we usually see a lot of anxiety and worry that goes along with that. And we definitely see that with people with PWS for many of those different aspects or areas of their life that they just truly are not able to deal with. Sleep disturbances are usually a sign of psychiatric disturbance, but it's also a physical disturbance as well. There's been a lot of research that shows that there's disruption in the circadian rhythms. Like I said, sleep apnea is very common. And when a person is not able to get restful sleep, then we see that manifest in that person's ability for cognitive functioning. It can affect their memory. And when people are not able to recall things appropriately, they may fill in different gaps that they experience. And we often see that the person might become belligerent and irritable when they are not remembering things that other people are remembering. We see this so commonly with people that are experiencing dementia, the early signs of dementia, and that irritability and physical aggression is actually very common with dementia as well. And part of that is because the brain is not able to complete a lot of its regular functions appropriately, including that memory aspect that's associated with dementia. But we also see this sometimes with people that are not able to truly attend to what's going on and be aware of what's going on around them. So we see this with people with ADHD. We see this with people with other physical abnormalities, such as visual and hearing impairments. Sometimes we see that irritability and that belligerent aspect or feature kind of arise because they're not really being able to track everything as it occurs. And that might be why some people with PWS are diagnosed with some of these psychiatric disorders. Oftentimes as well, we might see some psychotic symptoms. And by psychotic symptoms, some people with PWS truly do report some hallucinations. They may see delusional thought content. But we also see some of those other psychotic symptoms that are easily overlooked, such as depersonalization, derealization, that feeling as though things really aren't happening to you right then and there. This really isn't happening to me right now. Almost at seeing yourself from outside of yourself in a given moment. We also see some of that disassociation that might occur in a person that is experiencing psychosis. So psychiatric features continued. Oftentimes we see obsessive compulsive behaviors. And I think again with that impulsivity and that compulsiveness, it's something that's very inherent to people with PWS. But we see the anxiety, the worry, obsessions about things, specifically food, compulsive behavior, hoarding things, especially food items, arranging things, putting things in order. Again, these are things that a person can control, and it begins to manifest itself in these perfectionistic qualities. We often see hyper focus on the body. And if a person with PWS was to get a mosquito bite, we often would see that this continual picking of the skin. And it's not necessarily so much that the person is feeling that their skin is itching uncontrollably, but there is a lack of sensation when they're picking at that skin. Most of us would know that as we're scratching our mosquito bite, that when we draw blood, that's a good time to stop. And now we're gonna have a scar maybe, or it's gonna scab over and things of that nature. But with PWS, you don't necessarily have those same sensations. Same thing with self-injury. If wounds are inflicted, that person might continue to go after that wound and begin to perseverate on that wound, pick at it, infect it. And then, like we know, PWS infections don't occur and they don't give us those same signs that they would with other people who do not have that diagnosis. We see a lot of ritualistic behaviors. And again, I think that this ritual-like behavior is, again, pertaining back to that person's ability to control what they have control over, to order things the way, sequence things, do things first. We see a lot of that OCD-like behavior, what we would consider OCD. And again, just to remind everybody, something becomes a mental illness when it begins to affect that person's ability to function socially, academically, and occupationally. So some people may have some tendencies. Some people are perfectionistic in nature. But if they're able to function socially, academically, and occupationally, then it's really not necessarily a mental illness. It's more like a personality feature or a personality trait. But a lot of this, for people with PWS, this ritual-like behavior, these qualities of perfectionism, compulsivity, impulsivity, it truly does affect every aspect of their lives. It might affect their ability to maintain relationships. They struggle to be able to naturally adapt to the naturally evolving rhythm of our day-to-day lives. So when things happen unexpectedly, a person with PWS would not likely be able to manage that. And when everything is in its place and in its order, that's when the things are best for them. But that rigidity, we all know that does not necessarily lend to the flexibility that's needed to go throughout life. Weather can change things for us. People coming to visit out of the blue can change things for us. And we naturally are able to adapt to those situations. But people with PWS are not. And many of you might be thinking that some of these features of PWS actually sound a lot like the people that we serve and support that are diagnosed with autism. And actually 25% of all people with PWS are also diagnosed with autism as well. So you definitely see that those overlapping features between the two diagnoses. All right. I feel like I've been rambling. So I hope that this was helpful in explaining what PWS is. And now would be, I think, a great time to stop. And if anybody has any questions, I can try my best to answer some of your questions.
Okay, we just have a couple. Appetite suppressants have proven to be ineffective with affecting this food drive. Are there any other research items out on the horizon that you know that may be helpful with this?
I am not 100% sure. I would have to be completely honest. I have not done recent research in regards to the appetite of a person with PWS. I know a lot, and we'll talk a little bit more about this, but growth hormone therapy has been very effective as a treatment for many different aspects of a person with PWS. And I just can't remember off the top of my head, but I know I was reading an article recently where they were talking about growth hormone and how it affects appetite. But I cannot recall off the top of my head right now. So I apologize. But we do have some resources for continued research. And as I talk, sometimes things come back to me, so I might remember this as we go forward. I also don't always have control over my cognitive functions. But at the end, I think our last slide has some PWS resources, and you might be able to find some answer there if I can't think of one in the meantime. But I'll keep stewing on that as I continue to talk. Thank you for that question.
And I know too, there's the Foundation for Prader Willi Research. I think it's fpwr.org. If you're a person that's interested in research, they have just a ton of research going on. It will talk about what's kind of coming up, clinical trials, research like that. So if that's kind of what your interest is, I can make sure we add that if it's not in the presentation at the end. I can't remember if that one's on there, but we can send that out. But they do have like the real scientific study and stuff in there and what's kind of happening. I didn't see anything. I was trying to poke around specific to that, but they do have a lot of really interesting things going on through this. There's also a couple Facebook, if you just put Prader Willi in your Facebook groups, there's a lot of like research things going on in there too. I have liked a lot of them and I see them pop up. Okay, so the other question was, biologically, what happens in the brain to activate that switch from failure to thrive to the overthrive? Like, how does that happen?
What happens in the brain for it to switch like that? Yes. I'm not sure. It has something to do with the, wow, I've never had a training where people have asked so detailed
I know, and they're coming to me personally, so then it just keeps showing up in the big chat box.
I love it though, because sometimes I don't even get questions and usually I have an answer, but I don't know honestly what that switch is. And I'm not sure that everybody knows, or any of the researchers really know what happens in the brain to switch. All I know is that because of the genetic or the genes that are not expressed when that person is developing within the womb, that has thrown the hypothalamus out of its normal functioning. So we consider the hypothalamus kind of like that barometer that's keeping us all even. And with PWS, because certain genes are not expressed, that balance is off kilter. So we see this underproduction, and the body naturally, with anything that is occurring in it, tries to correct any problem. That's even like in other issues, not even related to PWS, but we see issues like within cancer, where there is an abnormality of a cell, and then the body's natural defense is to continue to produce cells. But when that cell is an abnormal cell, that's how cancer spreads, because it's the overproduction of that. And the body is stuck in this loop that it can't necessarily get itself out of without some other intervention, such as chemotherapy and things of that nature, to get rid of those cells that are not functioning appropriately. So when we have this homeostasis, and it is leaning this way to underproduction, that body is still trying to correct those problems. And so then something happens during that development where it really revved itself up, like that car engine type of analogy that I use, where you're trying to turn the ignition and turn that over and over and over. And then finally it clicks, and then that engine revs up. And now we have just tipped the scales to this side, and then the body's keeping going from there. But the source of it all is that the hypothalamus is not functioning appropriately, in the sense that it's not regulating things. But even when that switch happens, it doesn't necessarily mean that every aspect of the person's biology is in that overproduction, because we still see a lot of issues like with hypotonia that persist into adulthood and things of that nature.
I think from a family support aspect, that's a hard thing for our parents to grasp, is those first couple of years when you're really trying to adjust to, that failure to thrive and the lack of emotions and crying and trying to get as much nutrition in them and all of that. Then all of a sudden you kind of go the other way. It's like whiplash. So all of a sudden now you have more dysregulation and, the over emotional and that sort of thing. So that's really hard for a parent to, make that shift back into the other one.
Mm-hmm. Yep.
Next is just more of an observation. Someone provides support to teenagers and young men with Prader Willi, and they seem to really notice during the puberty years that dysregulation is really amped up, and want to know if that's due to the impulsivity and the shifting you were talking about with the anxiety, or if there actually is some sort of correlation with those increased emotional things going on during the puberty years.
So I think that you definitely see that. I think that you're correct on both of those aspects. I think that we definitely have impulsivity, which is just inherent, and it's also inherent with people with intellectual disabilities. So that's going to be something that we're all going to have to deal with, with people with PWS. But then a lot of times, it's almost like that adolescence goes into this phase where it too is delayed. And then everything, and if you recall back to when you were an adolescent, and just the hormones that would occur, and your mood lability that would happen when your parents tried to ask you to do things and things of that nature. You're all over the place, and somebody not saying hi to you, they would send a person into tears one day, like that kind of thing. Well, you can imagine that it's delayed, and then it is there and happening. And when that happens, depending on the person, sometimes you're going to see that as a flood. And then with other people, you're going to see it as a gradual thing. So it's really that those hormones kicking in, because it is like a delay. And then also, it also depends on how those sexual organs and those hormones that are associated with them develop. Oftentimes, we definitely see that underdevelopment of those sexual organs. And then that alters how those hormones are expressed within the body. So I think that both observations are correct in that sense, that yes, we have the impulsivity, and whether we're talking about PWS or any other disorder, with adolescence, impulsivity is definitely there as well. So that is absolutely a contributing factor. But then when we see this delay in that adolescent functioning in regards to their hormones and things of that nature, that can further impact it.
Okay. What's the average life expectancy?
For someone with PWS?
Mm-hmm.
I'm sorry, but I can't recall. I think we've had this question before, and I gave a an answer, but I can't recall off the top of my head. I know that it is not as long as an adult without PWS, and the reason why I'm not giving an answer is because I'm thinking of something like a numerical answer, but I can't think of one. But we often see that there is a shorter life expectancy for a person with PWS, and it's because of all of the medical complications that the person experiences. So I've gone through so much, and I felt like I was completely rambling in this first half. But even with all of the information that I was spewing out there, there's so much more that I didn't even begin to touch on. For example, I didn't even mention diabetes and how diabetes is incredibly common for people with PWS. Again, when you have obesity and you have that fixation and that inability to satiate, that person's going to keep trying to eat. And of course, when you are experiencing sleep apnea, which is associated with obesity, your brain is going to crave the starchy and, junky type foods, sweets, all kinds of fats, all kinds of stuff like that. Those are the things that you want when you have sleep apnea. And it's because of your body not being able to truly repair itself during its rest. And so a person with sleep apnea is struggling with obesity already, but then it adds to it because then you're craving all of these poor foods. With that being said, it is very common for a person to have cardiac issues with PWS because of the obesity, the food that they're taking in, and then a lot of times the inability of their body to really engage in those regular bodily functions. Again, blood pressure might be incredibly altered because of PWS and the hypothalamus not being able to truly regulate and produce the appropriate hormones. Heart rate is oftentimes affected as well. And again, everything's interrelated. Our brain is not regulating things, plus the person's overweight, plus the person is seeking out an appetite or nutrition that is not healthy. So it creates this perfect storm, so to speak. There was another point that I had there in terms of something that would lower the lifespan. Oh, so cardiac issues lower the lifespan, anything related to obesity, as well as the inability of the body to be able to eliminate itself. So to have bowel movements, constipation is so incredibly common, but then the bowel can become compacted. They experience gastroparesis. They experience necrosis of the bowel. All of these are life-threatening conditions. But now we go back to that brain, and the brain not sending and receiving appropriate signals, not being able to interpret appropriate signals. And so by the time that the person is saying, hey, I don't feel well, or they're starting to puke, or they're starting to say, I can't go to the bathroom or whatnot, it's usually now past the point of normal problems that a person might experience. And that person now has to have some type of serious intervention because their bowels are not working, their heart is not working, their cardiovascular system is not working, things of that nature, which then the treatment for that is often some type of surgery or invasive medical treatment. But because of the narrow airways, the saliva issue, then surgery becomes very risky. So off the top of my head, and I apologize, ever since the pandemic started, my brain is just wacky. I can never remember anything, and I'm sure many of you might be able to relate. Yes. I can't remember like an actual numerical span, but oftentimes the lifespan for a person with PWS is shortened because of all of those medical concerns and those factors, those physical factors that are present for a person with PWS.
Sure. I think too, even just to tie off of that, if you've worked with a child diagnosed early, you'll see the importance of a child with PWS having a whole team of people. I mean, usually it comes with, you have, like you said, the dietitian, the sleep apnea team, the nutritionist, the cardiac, the renal team, and just those importance of all those team players coming together. So if you're working with someone with PWS, even to find a primary care doctor that knows about PWS and what to look for, the signs and symptoms, things like that, because it is so imperative that at least you have your core team have some knowledge base on what PW is. I know resources are lacking in Illinois, especially in the adult world, but if you can find somebody that at least has a little bit of knowledge base on that, it is very helpful. And then of course, if you can get that early diagnosis as a child and create that team as they're young and move with them, that's always beneficial. Just one last thing before you move on to interventions. We have a lot of questions about interventions, which you do talk about. But if someone sees a lot of these different things you're mentioning in their current caseloads, can they get this diagnosis as an adult, or what would they, who would they go to look into, if Prader Willi is something that somebody has?
So you can receive this diagnosis later on. Oftentimes it is diagnosed within the person's development, but you can receive a diagnosis later on. And there is a couple different ways for a diagnosis to be confirmed. Sometimes it is through verbal report and saying these are all the issues that have occurred. They take into account behavioral characteristics, the person's development, things of that nature, and you can receive a diagnosis that way. But then there's also genetic testing for this. And even if somebody has the diagnosis from verbal report and like just a verbal estimate of everything that's going on, I still would urge genetic testing so that it can be confirmed, because as we all know, with supporting people with disabilities, so many different diagnoses overlap, so many. And we've given this training now, I don't know, at least 3 times, maybe even more than that. And I always get, or we always get the question about, I'm seeing this person, they have all these features, but they keep saying they don't have PWS because they've done the genetic testing. That might mean that they have something else that is attributing to this. We often can see increased appetite as that hallmark for Prader Willi. It's one of the most observable things that we can notice for a person with PWS. But that's not the only culprit to a person that has that increased appetite, inability to be satiated, and then all the different behavioral and psychiatric issues that occur because of that person not being able to get access to those food items. I mean, sometimes it really is because of side effects of medication that this person is engaging in very similar behavior. But that's again why we give just the facial and the different features of the person's stature, so that you can go back and kind of look and see, are these some clues? But then you really should go forward with that genetic testing. And I think it would probably be best to get a good confirmation on whether or not the person really truly has PWS or not.
Okay. I think that's it. If I missed any questions, go ahead and put them on the bottom, and then when we get to the next section, I'll make sure I bring them up again.
Okay, let me take one more sip. Okay, let's go on. So that was the first half was our description of PWS. Now we're going to talk about some interventions. Or some treatment considerations. Again, you can adapt these. This is more food for thought, things to consider when you're supporting somebody with PWS. Oftentimes when we're providing supports to a person with PWS, obviously we're going to need to take a team approach, and a well-rounded approach is best. Oftentimes we would want to focus on prevention versus reaction, but we also have to make do with the ability and the information that we have. The person from PWS will benefit from a consistent approach and also from structure. We should really focus on positive skill acquisition when we're talking about how to address behavioral issues. And PWS obviously is not something curable, but it's something that we can improve upon, meaning that we can improve a person's situation with our support. Now, a lot of the treatment considerations that we're going to talk about are not going to be the medical treatment considerations, only because we don't necessarily have control over that. But there is food for thought, and Anna actually just highlighted this. When you are dealing with somebody with PWS, we obviously are going to want to engage a team of people to be able to provide supports, because PWS affects a person in so many different areas of their lives. So we should consider that the person has several different areas that we need to make sure are being tended to appropriately, so that we're not missing something that could get out of hand quickly. And again, because the person's not going to report this. So ENT issues. So, our eyes, nose, and throat. Or ears, nose, and throat, sorry. But also eyes. We need to think about that person's ability to breathe appropriately. ENT comes in for sleep apnea. We need to visit a eye doctor because vision is often impaired. And if the person is not reporting these issues, then that can really affect their behavior as well. A lot of people with developmental disabilities, when they can't see something or hear something, they're not necessarily going to communicate that, but then they're going to hide that. And then they're going to have different behavioral expressions, maybe even outbursts, to cover up from whatever impairment that they're experiencing. And that's something that's just very primal. It's very innate to humans and even animals out there. You don't necessarily always show the weaknesses, but you see different behavior in its place. With the thick saliva, that often leads to dental cavities. And also the poor diet. So if the person is really seeking food, we need to consider that this person should have regular dental checkups and make sure that everything is functioning appropriately in their mouth, as well as if they are experiencing any type of tooth decay or whatnot, that it's being treated so that that doesn't, get out of hand itself. Again, everything is interrelated. And oftentimes gingivitis, plaque buildup, everything of that nature is also a good signifier that a person is having some cardiac issues. So if we are taking that person in for their dental checkups, and they're starting to notice that there's an increase in gingivitis, periodontal disease, anything of that nature, that also might be a good clue for us to think about when has this person also been evaluated in regards to their other cardiovascular health. So we should consider whether or not the person is getting regular blood pressure, whether their heart rate has been taken or their pulse, and what kind of treatment that they should be receiving for any concerns regarding hypertension or hypotension or anything of that nature. Again, ENT or the respiratory doctor, sometimes unexpected and unexplained death has been associated because of breathing issues at night. So we really should consider being able to work with a person regarding some of these breathing issues. Now, before anybody goes and asks this, I know that having somebody wear a CPAP in our population is incredibly challenging. But that doesn't necessarily mean that we don't get the evaluations and we don't try our best to have that person learn to tolerate different masks or different procedures. And even nowadays, they're coming out with some surgeries that a person can do to have a little bit of I think it's an implant that goes in and then it regulates their breathing. But again, surgery is very risky for a person with PWS. Some other things to consider, their gastrointestinal. GERD is very common. Like I said, gastroparesis. There's so many different things that could occur for a person not being able to eliminate properly. So does that mean that we are taking data on their bowel movements? What is that data showing? Is that person independent? What kind of support do they need in regards to being able to go to the bathroom, things of that nature? We should be collecting some of this information so that we then can inform doctors about what is going on with that person. I'm trying to think of some other things. Also consider, other aspects such as the musculoskeletal system. Excuse me. Many people have hip dysplasia. Many people struggle with osteoporosis. All of these factors might not be something that we're readily aware of, but can impact the person's mobility, can impact that person's desire to engage in activity. And some of this rigidity that we might see, and this resistance and this non-compliance that we might see, might be that the person is not really understanding what's going on inside of themselves because they're not receiving the appropriate signals, and they might not be able to articulate why they are refusing to do certain things versus others, but they might not be able to, and something might be truly wrong internally. Let's see. And then, of course, there's a psychiatric component where it would be quick for us to want to medicate the person with psychotropic medications. A person with PWS can be medicated with psychotropics. However, we do have to consider the ability to metabolize. So a regular dose for somebody who does not have PWS might really impact that person and create some of those side effects that we talked about before. So they might have to, the psychiatrist might have to play with different dosing and find the right mix for that person with PWS. But the best thing that we can do in conjunction with all of these other treatment considerations is to really look at the things that we have control over. And that's really more so social skills training, exercise, structure to their diet, behavioral interventions, and then when necessary, we can report on medication and we can seek out some help with growth hormone therapy. Especially when the person is in their development, growth hormone can be helpful, but it can be helpful specifically for the hypotonia. And if that person's able to build some of that muscle mass, then that might help out with all of the body's other functionings that are impacted because of that hypotonia or poor muscle mass. But like I said, we're going to focus in on the things that we have control over as mental health professionals and direct care professionals. And it's not necessarily going to always be the medication or the growth hormone therapy or the ENT doctor and stuff like that. But it's going to be some of the social skills training, the development of coping mechanisms, the adherence to a diet, things of that nature. So first up, behavioral interventions. Whenever we're delivering any type of behavioral intervention, we want to be very clear. We want to provide instructions. We want to model the behavior that we're asking for the person. And then we want to engage them in some type of task where we can then give them feedback and reinforce what we want to see. That is how we are able to have someone acquire a skill and begin to apply that skill in different environments. And practice makes perfect. We rehearse different skills, we reinforce them, and we continue to give them situations where we can really see them engage in different coping mechanisms. We have to also then look to the environment and see what we can do to give this person the best shot at utilizing the different skills, the coping mechanisms that we teach them. So let's think about transitions. Transitions are often very challenging for a person with PWS. Again, we have that component of impulsivity. We have that component of control. And oftentimes there's a lack of control. So then the person compensates by really trying to control what's coming. We also have this desire from a person for PWS to know what comes next. So when we know that the transition is happening, we want to foreshadow, we want to prepare the person, and we want to have some things in place for us to do to be able to get that person unstuck from whatever it is that they're doing in that moment. Sometimes that means that could be a compulsive behavior that they're engaging in. Many times it could allude to a person's reordering things, writing a list of something, whatever that may be. And now we need to change the task and move on to something else. What can we do to get this person unstuck? Like I said, that might involve foreshadowing a change, using timers, using visuals, and then utilizing de-escalation techniques when it's time for us to begin to prompt that person to engage in that transition. There's a lot of different things that you can do for transitions, but this is more like food for thought in conceiving and conceptualizing how to support that person with PWS. So when there's a transition coming up, it's not just we need to prompt the person and see what happens. It's actually, what are the steps that we need to take to get to that transition? What are the steps that we take during the transition? And then how do we debrief after the transition? Behavioral interventions also includes an increase of exercise. Exercise is actually a coping mechanism, something that maybe most of us don't always enjoy, but it reduces anxiety. It can distract a person from what's bothering them. It makes a person feel better. And if a person feels better, then they're going to do things that they enjoy. They experience joy. Then they're going to interact better with other people. It can be such a chain of events when it comes to exercise and utilizing this as a coping mechanism. I think I have a slide about this, but I'm already going to jump ahead for a second. Research shows that when a person with PWS has structure around their eating, they engage in exercise, and they begin to lose weight, there is a correlation that their behavior will improve with these measures. So the healthier that they get, the better that they follow their diet, the healthier choices they make, and the more exercise and the more structure that they have around their nutrition and their health, the more their behavior improves. When a person begins to become very perseverative on food, they start to get access to unhealthy food, they start to gain weight, there is a direct correlation with an increase in challenging behavior. And this actually makes sense for anybody that's ever been on a diet. You can imagine that you build momentum. When you start doing really well with your diet and you start to see those results, you actually start to feel better and you start to make healthier choices because it's good. But then you have a day where, you cheat. And when you cheat, you go for the greasiest, starchiest, maybe the most chocolatey thing that you can find. And once you have that one thing, that's like a drug. Then your body starts to want more of it. And oftentimes where we struggle with our willpower is because it's so easy to go from, I'm just going to have that one little cookie, to I'm going to have that one cookie and I already cheated, so now I'm going to have those cheese fries. And since I'm having cheese fries, well, I got to wash that down with the meat. And I'm going to have Italian beef or something like that. Who knows? But it's so easy to get off track, and then that bad food becomes really addictive. The same is true with a person with PWS. Once they get off track, it's really easy for them, because of their different functioning, to really go hard, and really there be an emphasis for getting those bad food choices, or making those bad food choices. And we see that with PWS. So we want to enrich them with activities that promote their strengths. We want to engage in social skills training, because oftentimes a person with PWS might feel as though that things are out of their control. So how do we optimize their social skills to get their wants and needs met in an appropriate way? We do social skills training with them so that they can be effective in their personal interactions with others. And again, being effective means that they're feeling better and they're getting other needs and wants met versus the ones that they actually have to go without, which is some of those food items that they might be perseverating on. We make environmental modifications as needed. So we consider the physical setup of the environment. What kind of access do they have to certain food items, the refrigerator, the cabinets? But then not only that, but what kind of food items are in there in case that we can't do some of those environmental modifications, such as locks and things of that nature. And of course, we provide close supervision, especially in the times that the person is struggling. But we should provide close supervision in a perfect world. I know we're all in a crisis nowadays in terms of being able to have enough people to provide supervision, but we do our best. And we're always doing our best, and we can do better as time goes on. But providing close supervision for a person with PWS is especially important because of that impulsivity and that impulsive nature in their behavior. So specifics. In regards to emotional expression strategies, foreshadow changes, identify safe people to go to, identify safe areas where they can express themselves if they are starting to notice that they are getting upset. This is also part of social skills training and emotion regulation training. Think about how does that person recognize that they are becoming upset? Because they're impulsive, there's many instances that a person goes from 0 to 60 in a split second, and before you know it, they're engaging in self-injury and physical aggression and property destruction and all of the above. But that doesn't necessarily mean that a person can't learn to stop and think before they get to that point. And that's why we start to foreshadow some changes. We work on that emotion regulation. We identify people that they can go to, how to access help, things of that nature. And with them engaging in these behaviors and choosing to do some of these strategies versus others, then we can start to reinforce how effective that really can be instead of engaging in that self-injury. We model the use of words and pictures when we're sharing our emotions, to express ourselves verbally rather through our physical behavior. We teach people to emphasize behaviors that we want to see and behaviors that we don't want to see. So we ask them to express themselves in certain ways over others. And any effort that we see a person making, even if they start off on the right foot but end up engaging in challenging behavior, we still recognize their efforts and we reinforce those efforts. And especially with a person with PWS, we're not necessarily reinforcing a person with food items, because you can imagine this could be very dangerous ground that we're treading. So we reinforce them in so many other ways. There are other things that a person can earn, including natural reinforcers, such as spending time with us. If we have a good rapport with somebody and we take the extra time to spend with them and we let them know, I'm going to hang back for a few minutes just to hang out with you because I'm so proud of you for making all of these great attempts at trying to stay on your diet. I think that that's wonderful. Sometimes those interactions are just as priceless as some of those hot ticket items, such as money, food, outings to preferred stores that some of our people communicate that they really want. So skin picking is often a big problem for people with PWS. So what can we do here? And one of the things that we can do is provide a person with many activities that keep their hands busy. Coloring, doing puzzles, engaging on the computer, video games. Oftentimes when we were growing up, our parents said, oh, those video games are gonna rot your brain. Well, you know what? Video games also have another purpose, and they're wonderful distractors. and it can distract you from the worst things that you're experiencing in life. You get consumed in a video game, and then everything else kind of goes away until, later on, when then you have to think, oh, wow, I forgot I was upset today. But activities that can distract a person and occupy their time, especially their hands, can be very helpful in avoiding some of those target behaviors, such as skin picking. We also have to consider the environment and the behavior of the person. If the person is going to the bathroom frequently, do they have an issue? Are they dehydrated? Are they drinking too much? Because again, a person can experience water intoxication when they have PWS because they might be supplementing food intake with liquid intake. And then water intoxication has all kinds of different issues that might occur with it, including washing out a person's medication that might be necessary to keep them on track with their physical and mental health. So if the person's going to the bathroom frequently, what's going on here? We need to do some supervision and some investigation, because it might be that that's the unstructured moment that they have to engage in that skin picking, but it also could be a signifier for other issues at play here. Teach a person to be engaged in their health. So it's not that they create an issue by opening up a wound, but why not teach them about their wound, the consequences of having an infected wound, and then how to engage in first aid? Because skin picking is going to occur. We can get them distracted, we can minimize it, but if the person really skin picks, it's going to likely take a while for them to stop engaging in that behavior. So in the meantime, let's also teach them to be appropriate with it and be able to administer first aid to themselves, or even know when to ask for that first aid. That actually goes a long way. Encourage the person to utilize lotions and other things that might soothe any issue that they are experiencing, and to rather rub on lotion versus actually engaging in that scratching and skin picking. And then I actually can't see the bottom one. My screen, my bar is blocking this. But hopefully you can see it and it's something helpful for you. Okay, sleepiness. We've got people with PWS who have issues with sleep. Daytime sleepiness is very common. It's also common for people with sleep apnea, just in general. So we want to try and engage a person during the day so that they don't develop these reverse sleep habits where they're sleeping during the day and up during the night, because that also creates problems for the person, especially with their scheduling. And we know that people with PWS are very rigid and can struggle with changes to their schedule. So provide a structured visual for scheduled breaks when they're engaging in activity. Get a person up and moving and engaged. Actually give them in that schedule, maybe they do require a short nap, but also foreshadow that for them, give them structure, reinforce the ability for them to come back from that nap. And then assist them in communicating the problem to healthcare providers. Obviously, this goes beyond what we can do if they truly are experiencing sleep disorders. But these are some things that we need to think about as food for thought in regards to dealing with a problem that might seem challenging in the moment, but that will be much better, have a much better outcome in the long run if we take the time and work at it now. The longer something goes without being addressed, the more likely it will become a habit, and the harder it is to undo that habit. And the more tantrum-like behavior that we will see in response to us trying to involve that person in engaging in a different way of interacting. So do the work now, because it'll pay off in the long run. Severe stomach illness. Monitor signs of constipation or other bowel problems. Encourage a high fiber diet. Increase intake of water, but appropriate, because this also can go the other way. Again, monitor how the person is going to the bathroom. Are we taking data about bathroom habits? Monitor the person when overeating and what kind of foods that they're overeating. Sometimes you need to dig into a person's history to find out if they've ever had issues with pica before. And then, of course, you need to consider environmental modifications if that person does have a history of pica and is in danger of engaging in that behavior again. And of course, understand the side effects of psychotropic medication, because oftentimes these side effects of psychotropic medication can involve things that affect our digestive system, whether that's an increased appetite, constipation, frequent diarrhea. Frequent diarrhea also can create issues that could cause a person to engage in rectal digging, picking of the rectum, which is also very common for people with PWS. Compulsive tendencies, setting up activities for success. Start with small tasks that they're able to do within time constraints, and then build from there. Think ahead and follow through. Always break down things for people and create positive momentum. I like to use an example that one of my former colleagues would always use. We often prompt the people that we serve and support to do tasks that we take for granted. So, for example, consider making a bed. Consider all the different steps that go into making a bed. You have to identify the fitted sheet. You have to identify the first corner that you're going to put the sheet on, then the next corner, and it's usually an opposite corner. And then you go from there, and you can break down to many multiple steps. But oftentimes we just tell a person, oh, it's time to go make your bed. And we assume that they're going to be able to understand all the different components about that. But especially when we're working with people that have some compulsive tendencies, we need to break tasks down into small pieces, small obtainable pieces that they can do, and then really reinforce the heck out of them being able to complete those tasks. That produces momentum to be able to do things. And when you have that sense of completion, that truly does make a person feel better. And then feeling good really just translates to so many different areas of their lives. Consider doing non-preferred tasks before preferred tasks. Consider how you're going to transition from a preferred task to a non-preferred task. Sometimes this is involving when we're starting to use that first then language. First we brush our teeth, then we have breakfast, or whatever that might look like in your respective environments. We provide structured schedules, and sometimes visuals are very effective for our people. We always have to consider what the person's individual characteristics and preferences are. But with people with PWS, I have experienced where they really do enjoy having a visual representation of what they are being asked to do, so that we can account for any of those different learning abilities and learning capabilities. Again, people with PWS lots of times are very articulate, and that sometimes lets us overestimate their ability to complete tasks. The visuals sometimes really help to capture everything that we're asking a person to do. And then they also can use their visuals to check off everything that they've done. And at the end, you can see all the work you've done. I actually do this day to day myself. I make a list every day and I cross it off. And that just makes me feel better and like I've been productive that day. Routines are obviously highly preferred. So consider, what kind of routine can we develop in conjunction with this person? And we try to let the person know what to expect, because that often is very vital in our success with providing people with supports with PWS. We can reframe things when they're struggling. If a person is obsessive or compulsive regarding tasks, provide them with the opportunity to take ownership over it. We validate their thoughts and feelings. We can let them know that a lot of people experience these aspects as well. And this is what other people have done to deal with these different aspects. That's reframing and empowering a person. We clearly communicate expectations and provide specific praise. So I really like how you handled this blah, blah, blah situation. It seems like you really have been practicing your skills and you are able to manage it effectively. I don't know, that's just an example. If a compulsive activity is calming and is not harmful to self or others, it may not be a problem. So this is where a person is compulsively making lists or compulsively ordering things in their room. It's problematic when it is really interfering with their social, occupational, and academic functioning. But it can also be a coping mechanism. And we consider the alternatives. If this is the alternative to self-injury, then we consider this a win, and we can continue to evolve with the person and shape their behavior so that they can manage their time effectively. But at least they're engaging in this activity instead of engaging in rectal digging to the point where they're damaging their rectum, and then they need continued treatment, which is something that I've seen from people with PWS before. Perseveration and obsessive thinking. The person with PWS will often repeat the same question over and over, even after they have been given the answer. It has been described as a neurological switch that will not turn off. Perseveration can lead to increased anxiety and loss of emotional control. So how do we respond to this? We validate a person's feelings. We let them know that we understand how they can feel about a certain situation. We give them options of things that they can engage in instead of continuing to engage in that perseveration. We attempt to engage in problem solving. And sometimes people with PWS have an aptitude for problem solving and might really engage in this. We get a commitment to utilize coping mechanisms, coping strategies, and then we follow up with them to continue to troubleshoot what was effective in this moment and what wasn't. We set limits and we set clear boundaries, and we avoid power struggles with the person. We again try to empower them to do something to get through a difficult situation. And then when we see any effort whatsoever, we reinforce that effort. And the most effective reinforcement are those natural reinforcers, such as taking the time to follow up, troubleshoot, laugh with them, joke around with them, although we should be careful about humor sometimes because our people cannot always interpret sarcasm appropriately, but enjoy talking about, what TV we watched the night before. Sometimes that's the best reinforcer that we can do, or anybody that we serve and support. So when somebody is struggling with some of that emotion modulation, we often look at the function of the behavior that they're engaging in. We're avoiding power struggles. We avoid reasoning with the person if they are extremely agitated. We often want to de-escalate the person to a point where they feel more calm, and then we can go through and start to reason with them. If we're reasoning with them at the height of their frustration, they're not going to hear anything that we're going to say. And they're probably going to look at us as being very aversive, and any aggression that they might have been directing towards their source of frustration might be then taken out on us. So we de-escalate, then we can start to problem solve and reason. We engage in skill building so that the person is able to learn that skill set for coping. And we work with the person to develop different safety plans so that they know that when they become triggered, and they're feeling certain physical sensations, such as their heartbeat, or they're starting to feel other signifiers of being angry, that they have a roadmap of what to do in these circumstances, how to seek help, how to seek support, so that they can get through the situation and avoid engaging in behavior that is damaging to themselves and or to others. And with all of this being said, we might engage them in DBT, or dialectical behavior therapy, which focuses in on distress tolerance, emotion regulation, interpersonal effectiveness, and conflict resolution. And then we have, of course, the skill system, which is an emotion regulation program that is specifically designed for people with intellectual and developmental disabilities. And it really is DBT for people with developmental disabilities. We engage in function approaches that are significant in behavior analysis. And then, of course, there is medication management, but there should always be caution when jumping towards medication for a person with PWS due to the differences in their ability to metabolize. Okay, so we have some time for questions, but I also just wanted to tell some of my experiences before. I've worked with many people with PWS in the past, and some people have been incredibly challenging, and then others have not. So there's still, even though the person has a diagnosis for PWS, it does not mean that they don't have that individuality that every person has. I've worked with a person that was at a state-operated developmental center for many, many years, and she came out of the state op and then went into ASILA, and she had a long history of doing best when she was in highly structured environments. She also had a history of engaging in self-injury when things deviated from her schedule. When there was ever any surprises, even that the specific staff member did not come to work on a given day, she would engage in self-injury. And what she would do is that she would rectally dig to the point where she damaged her rectum to the point where she had to have a colostomy bag. So her self-injury really had gotten out of control, and she had to undergo some surgeries in order for her physical functioning to continue. She was such an articulate person. She had so many goals, but she really struggled with the unknowns and unstructured time. And unfortunately for her, the SILA environment might not have been the best place for her because there were certain natural consequences of SILA life that she struggled to cope with, such as staff turnover. Such as downtime in the afternoon. She often did best during the day program, but then in the evening time where most people are winding down, this is where she would often become triggered because there wasn't some structure that was implemented for her. She did her best when she was in a structured environment, when she could engage in structured exercise, activity, and her meals were controlled for her, and she was able to begin to lose weight. When she was in a SILA environment, obviously the refrigerator was not locked up for her. She had different access to food, and that started this negative momentum where she was food seeking, engaging in pica-like behavior. She would rectally dig and injure herself to the point where she would have to go into a nursing home for rehab, all around these food issues. And she ended up going back to a state-operated developmental center where she then began to thrive again because she really needed that structure. And she was again able to work on losing weight and had everything set out for her in a sequence. And it might have been that just for her in that situation, that's what she needed to stay on track. But that's not everybody with PWS. We did work with her to be able to develop different coping mechanisms, and we did see some progress at times. But I don't think that she was able to engage in those coping mechanisms enough for the environment that she needed. And I think ultimately what might have been best for her in transitioning from an SODC was for her to maybe go to another environment that was more restrictive than a SILA, and then step down from there. But that hadn't existed at this time because this is several years ago. I think she might have been able to benefit in that situation versus going from a highly structured environment as an SODC to a SILA where there's structure, but not as much structure as an SODC, which is what she was used to. But on the flip side, we've also worked with some people who weren't even obese. We've worked with a person who had been diagnosed with Prader Willi and diagnosed with a a genetic testing, and they maintained an appropriate weight. They engaged in some challenging behavior from time to time, but their parents had done a lot of work in regards to their diet, that they really adhered to that diet. And overall, they did really well and they were a success story. They were referred for engaging in some physical aggression, but the physical aggression was better explained to transitioning in life from children's services into adult services, from school to day program, things of that nature. Once that person was able to transition successfully and additional supports were wrapped around that person and people were taking more time to set situations up and understanding what a person with PWS might experience, then this person did very well and still to this day successfully lives in the community in Asila and thrives. So those are just a couple of the experiences that we've experienced on the team over the years, supporting people with PWS. But I do encourage that food is a big component. Activity is a big component. Structure around food and activity, exercise, all of that really has been very impactful for a person with PWS. So these are things that there should be a component in all of our treatment plans to address a person with PWS, address their needs appropriately. So I'll stop rambling. We have a few more minutes, and even if we go past our time, I'll stay on for a little bit if there are additional questions, but anybody is of course able to jump off if they need to go. Also, Anna, I don't know if you provided in the chat your contact info or the contact info of someone in case they don't get their CEUs.
Okay, yeah, I'll put that in right now. Just again, we'll do questions in a minute, but just try to give us 14 business days to get them out just because we have so many. So they will be coming from somebody other than myself. We have other staff in the office helping. So just keep an eye out for them and give us 14 business days. Then if you haven't received them after that, go ahead and email me. I just put my email in there and I'll get it to you guys. Okay, so just a quick question. Have you ever worked with anyone who had PWS and Klinefelter? Did I say that right? Klinefelter?
Oh, Klinefelter, wow. No, I have not.
Okay.
So I couldn't say from personal experience in regards to how that might, relate to each other or things of that nature. But definitely other co-occurring disorders like autism, like I mentioned before, different psychiatric diagnoses like major depression, anxiety, schizophrenia, things of that nature, but not specifically Klinefelter's, no.
Okay. Yeah, and as you were talking just about the depression and things, I always, once we get into November, I always do my little chat that, Christmas and winter is coming up. It's really a hard time for this population, but especially PWS people. There's less vitamin D. They're not getting outside as much. Their social supports may not be amped up as much as in summertime. So we're looking at, maybe increase in depression or anxiety. We have home visits going on that maybe they're not able to go home because of, the parents can't support that food part. We talked about the medical parts of it. Now you have flu season and colds, and you have that decreased ability to communicate when they don't feel good, they can't vomit, the constipation. So just really being mindful of that as we move into the winter months and the Christmas season, that we need to kind of really keep an extra set of eyes on them and make sure we're really staying as consistent as we can. We're providing different options and opportunity, and that we really have our patience with them. Sorry, I got sidetracked by some questions. So just a really good reminder for us in general during these next couple months. Do you know if the genetic testing is covered through the adult waiver, or if Medicaid, Medicare covers any of that? We always get asked that and I never know the answer to it.
I know, you guys are really challenging me today.
I know.
I'm gonna have like PTSD from this. No, unfortunately, I don't. I really don't know about the insurance or how that has come about. Anybody that I've worked with was never in that stage of getting that diagnosis. It had been something that had been very established. So I unfortunately don't. I apologize.
Thanks, James, for bringing that up. Caregivers are also affected during these next winter months. I know myself, I help take care of my dad who has Lewy body dementia, and it's tough for both of us in the winter. So send some positive vibes toward the caregivers as well.
Absolutely.
Okay, well, I think that wraps it up. When we send out the CEs, we'll make sure that we send any of the resources that we mentioned. I did find a pretty good article that talked about life expectancy and kind of what the top reasons for death were. So I'm going to have you look over that, Mike, and if it's something you think we should send out, I'll attach that as well. And I think that's it.
Okay. Well, thank you, everyone. I really appreciate your time, and I hope that this was helpful. I'll be taking these questions, and next time I do this training, I'll be prepared. Take care.
Thanks, Mike.
All right.
Bye-bye.